Right. Good afternoon and welcome to the Department of Medicine Grand Rounds. I'm very pleased to introduce my colleague, Dr. Stephen Thompson, today, who is going to speak to us about continuous EEG monitoring in critical care setting. Dr. Thompson is an associate professor of medicine in the Division of Neurology. He completed his medical school training at UBC, followed by residency training in neurology at Memorial University. He then completed a fellowship in EEG and epilepsy with the Cleveland Clinic in Ohio. After a fellowship, Dr. Thompson joined the University of Texas in Houston, where he served as the director of the stereo EEG program. We were successful in 2022 in recruiting him to McMaster University, where he's working at Hampton Sciences in the epilepsy clinic and is leading the development of the epilepsy surgical program locally. He also oversees the EMU monitoring and has experience in continuous EEG monitoring in critical care. That's the topic today. Stephen and I were chatting a little bit about how the surgical program has progressed. I'm sure we can touch on that at the end as well through his talk today. Without further ado, Stephen, please go ahead.
Yes, thank you. So the topic for this morning will be, or afternoon, I guess, continuous CEEG monitoring, and mostly within the neurocritical care setting, but it's technology that does get deployed many other environments, but that is where it's chiefly used. And when we start the program here, that's where it will be used, I imagine. So it's a monitoring and a diagnostic modality that's long overdue in Hamilton. About 200 bits. Well, there we are. So we're going to talk about the indications for continuous EEG in the critical care setting and some of the roles it has to play in, for example, the management of status epilepticus and other acute neurologic disorders. And also, hopefully, you'll understand some of the ambiguity that comes about both with the diagnostic classification of some of the things that we see on this and then how that relates to clinical prognosis and therapeutic intervention. It's an area of a lot of active research. So first, just to set the stage, everyone knows kind of what I'm talking about when we talk about getting an EEG on someone. For example, in the outpatient, even inpatient setting, a routine study is usually 20 to 30 minutes in duration. Occasionally, and really just in the outpatient setting, we'll do a sleep-deprived EEG, which is usually closer to 60 minutes. What we're talking about here is running an EEG for much longer than that, typically around 24 plus hours. Some people would do it for less than that for various reasons, but that's usually what we're discussing. So it's a much longer stretch of data, of course. With it, we record the video as well, especially if there are movements of concern, but it's EEG deployed over a much longer haul. We do this in the EMU. We have an epilepsy monitoring unit on the 7th floor, which is really exclusively for patients with a question about epilepsy or other conditions related to that. There are the patients who are, walking in well otherwise. So we're talking about here using this monitoring capability in the critical care setting, and again, mostly the neurocritical care unit. So EEG for critical care monitoring is used for any reasons. I mean, essentially and simplistically, one can consider it to be telemetry for the brain. Its chief purpose really, and most centers first start with using it for seizure detection and management of status epilepticus, but it gets used for many other purposes, prognostication, post-cardiac arrest, and some centers use it quite well for monitoring of cerebral vascular change, for example, picking up early vasospasm. There can be changes on EEG that can be seen well in advance of other modalities. It's very difficult to deploy that in this way. Today, we're only going to talk about its purpose for the use in seizure detection in that management of status, which is, again, what most people use this for. So first, and importantly, how common are seizures in the neuro ICU? So patients who come into the unit and are unconscious for whatever reason, how many of them, if you look, what will you find to be having seizures at some point? This is a fairly old study, 20 years now, but it was one of the landmarks in the field. And the first thing to consider is that most seizures in this acute setting are going to be subclinical, or you could call them non-convulsive. Sometimes they can be very subtle clinical signs, but most of these patients can only be identified as having seizures through monitoring. Makes sense because, if patients are unconscious, they can't tell you how they're feeling. They can't, report, obviously, a deviation in their mental status. You have sometimes autonomic changes or potential, clinical signs, eye version or facial clonus or something like that can be manifest. But many of the, outflow and, higher order functions within the brain are impaired. So you can't know most of the time. So this study that I alluded to from 20 years ago was run in Colombia by Jan Clayson, and they looked at 570 consecutive patients who were monitored for either the purpose of seizure detection or unexplained altered level of consciousness. And in that cohort of patients, they found that close to 20% had detectable seizures at some point, and the vast majority of these were non-convulsive. In other words, they only knew that they were having seizures because they had EEG recordings. And most of these who ended up developing seizures and showing them did so within the first 24 hours. But patients who were comatose, sometimes it took longer than that. So that's what this graphic is meant to illustrate. Patients who are non-comatose, a vast majority will show their hand within the first 24 hours. Comatose patients, sometimes you need to wait a little bit longer. So one of the, this study was actually used to define some of the time frame that continuous EEG gets used in patients who are, typically non-comatose, have 24 hours of study and comatose 48, but this is obviously quite old data. So what is the presence of seizures in these cohorts of patients? This is a summary of a number of studies and distributed by pathology. And not surprisingly, the presence or absence of seizures depends highly on what the pathologic condition is. It's highest, not surprisingly, in patients who are what we call post-convulsive. So they've had a witnessed convulsive seizure, they stop moving, but they continue to seize on EEG. In patients with CNS infection, 10 to 30%, depending on which study you look at. Traumatic brain injury, it can be quite high. Post-anoxic, quite a wide range there. Stroke, either hemorrhagic or ischemic, excuse me, much less common than some of these others, but still upwards of 20%. One thing to keep in mind is how you sample in time. So this is a graphic of about an hour and a half's worth of data. One thing we do quite often with patients who are in the ICU or in the EMU is we use spectral analysis to help compress the data and make it more visually identifiable. You can look at long stretches and then hone in on what's relevant. I'm not going to, explain exactly what you're looking at here, but you can probably recognize there, 4 periods here that substantially depart from the background activity. Each of these would be a seizure, and this window of time is about 20 minutes. So that's about the length of a typical EEG. So obviously a 20-minute study does not give you a full sampling of what may be going on. Now, most of the patients who are seizing as frequent as this won't have normal EEGs. So there's usually some clue to it, but it just highlights how, you can miss if you only look for a short period of time. And if you do a routine EEG and you find a seizure on it, that patient's probably having an extraordinary number of seizures over the course of the next 24 hours if you were to monitor them. So it's not just seizures that we consider, and this is where the literature gets a little bit murky, and I'm not going to, go into some of the diagnostic considerations. But this graphic, again, quite an old one, almost 20 years now, is meant to highlight, if you will, 2 dimensions of continuum. So we are increasingly aware that patients can't, and EEGs can't be separated into a clear dichotomy of ictal, meaning seizure, and interictal, between seizure. But there are a lot of findings that we see that are somewhere in between, where we really don't know, what they represent. So that's really a diagnostic dilemma. That's something that the EEGer has to contend with. And there are a lot of, quite tedious classification schemes that are becoming increasingly systematized to help manage this question. The other and probably more important dimension is how this activity, whatever we're seeing, relates to neuronal injury. Are these seizures or whatever we're seeing adding to the injury of the brain? By definition, status epilepticus is ictal, and we certainly know very well that especially convulsive status epilepticus is very, very injurious if it continues. In between, just like the diagnostic dilemma, we have a therapeutic dilemma where we don't actually know, universally how problematic some of these activities are to the brain and how many of them need to be treated, and if so, how aggressively. And this is also old nomenclature. So these terms in here, most of them have changed since this graphic was presented, but this concept remains. And these are just some snapshots of kind of the things we might see. And this is some of the terms that get used in this day and age. And seizure obviously hasn't changed, but we call things now lateralized periodic discharges or generalized periodic discharges, or lateralized rhythmic delta, generalized rhythmic delta. So don't worry about this. I'm not going to, go into this in any way, just to introduce these terms that, we do tend to use in our reporting. So there are a lot of challenges with knowing what to do with these findings with respect to how indicative are they, how worrisome are they that patients who show these will have a seizure at some point if you let them run. And this has been looked at by a fairly large multi-center cohort. It was coordinated out of MGH, and they developed this tool for predicting the likelihood of seizures based on EEG features. It was a machine learning approach. It used a very large data set, so a multi-center study. And it was based on just the first hour of recording, which is actually longer than we typically do in the routine study. All these patients were monitored for a continuous period, but the first hour was used to design this system. So it was designed on a cohort and then validated in a second quite large cohort. And they kind of came up with the term 2 helps 2B, kind of modeled on the CHADS-VAS kind of concept, where you pick up scores, pick up points for various features that you find within the EEG. For example, if you have activity that's recurring at a frequency, 2 or greater, you pick up a point. If you have some of these funny terms that I just showed you the graphic of, you pick up a point. If they had a prior seizure known, they pick up a point. And then BIRD is another, it's effectively a very short subclinical seizure, picks up another point. So you add these up in sum, and then it's supposed to indicate kind of the risk for a seizure if you continue the study. And then this is just the 2 cohorts that we use, the foundation or validation cohort, which agreed quite well. So it's, I think, a very effective tool. It's now, accessible on some online platforms. It's actually pretty easy to find. So not only does it help with prognosticating the appearance of a seizure at some point, but there's also some time element that can be gleaned from it. So if you stratify by score, score of 1, or less, 0 or 1 or 2, you can kind of get a survival plot breakdown and inverted an idea for how long you may have to monitor a patient for to, if you will, rule out the risk of seizure. So if a patient has a score of 0, 1 hour was sufficient to, rule it out. 5%, false negative rate, if they have a higher, score, you need more time. So the score of 2, it takes a little bit longer for you to be able to to reassure yourself that this patient's not likely to have seizures. So 24 hours was sort of the cutoff to, if you will, rule out seizures as best you can. So one thing that can come out of this is it could, certainly be used to more efficiently stratify these studies, the deployment of resources. So if a patient is scoring 0 on the early EEG, it's probably no reason to keep them running for 24 or 48 hours. But if they're scoring, high, you might want to, give some more time to let the dynamic fully develop. So with this in mind, we'll go through some of the indications for continuous EEG, and this is as described by the American Clinical Neurophysiology Society. So not surprisingly, altered mental status after a convulsive seizure or status, so a patient who has had a seizure witnessed and then just isn't waking up, that is obvious grounds, and not just by the EEG societies, standard of care for measurement of status by Neurocritical Care Society and others, the European equivalents. Acute supratentorial brain injury, multiple causes from that, be it traumatic, be it ischemic, be it hemorrhagic, with altered mental status. These are also cohorted patients from a few slides ago that are at high risk for developing seizures, and also would warrant, consideration for continuous monitoring. Patients with just fluctuating mental status and who are not known to have an acute brain injury, probably lower likelihood of finding seizures with many other reasons. It could be metabolic or otherwise to account for this, but still, reasonable consideration. And then, like that score I just showed you, the 2 helps to be findings on EEG on their own could be, which were indicative of a high risk for seizure, but also be a reasonable indication. And then finally, and this sometimes gets used, also patients are in-house and they're doing funny things, and you want to try to understand, are they seizure or not? Because of course, knowing that will help you manage their care. So these are some of the indications, not including things like prognostication and ischemia monitoring, that can be reasons for running a continuous EEG. And one of the main ones, and really one of the etiologies for which it's standard of care, is the management of seizures and status. So again, most patients in an acute setting who are sick with impaired cerebral function are going to have subclinical or non-convulsive seizures. So you will not know they're seizing unless you run an EEG. I already showed you, the limitations for routine EEG. It's 20 or 30 minutes. It's a snapshot, and patients can easily be between seizures when you're sampling. If you catch a seizure, they're probably having a huge number more. And it's really tricky, and neurocritical care people know this well, to titrate seizure suppressant therapy, or if you need to go that route, burst suppression therapy, without an active monitor, knowing what's actually going on in response to your treatment. Yes, you can do routine spot EEGs over days, but it's really just that it's a spot. I mean, to borrow the analogy, would you treat a cardiac arrhythmia without telemetry? No, you wouldn't. You would just rely on, what your repeated 12-lead EEGs. Now, we do need to, recognize that we don't know wholly in every situation the therapeutic relevance of what we're seeing. Are these findings we're seeing, injurious to the brain? Are they additive to the toxicity? Or are they merely epiphenomenal? I mean, if they're merely epiphenomenal, they probably don't warrant treatment. So this is a very important question. There's a lot of research going on in this area. So seizures and status epilepticus, we know that for, but some of the other conditions are less clear. And it probably, it does depend on etiology as to, is what we're seeing adding to brain injury, or is it merely the effect of brain injury? And with that is the use of continuous EEG helpful to improve clinical outcomes? These are all questions that are being asked. So one way that that was asked is in the US, looking at large database surveys of patients. In one survey, which looked at ventilated patients, the use of continuous EEG was associated with a lesser in-hospital mortality than the comparison group who only had routine EEG studies deployed. And this was independent of hospital and demographic characteristics. Another a very large survey, and I think they had looked over, like, it's done automatically, obviously 7 million hospital records, I believe, found that in critical ill patients, continuous EEG, in this case 22,000 versus not, were associated with lesser in-hospital mortality. Though, strangely, it was really just for the indications of subarachnoid hemorrhage and intercerebral hemorrhage and altered mental status, but not actually in that cohort for seizures and status epilepticus. But when they looked closer, it was really beneficial for seizures, but not for status. And that probably is because status epilepticus and the mortality and morbidity that are associated with status is largely driven by etiology. So that's something that we need to keep in mind. So this is another kind of graphical depiction of a concept that is not all status, in this case non-convulsive status epilepticus, is created equal. So if you imagine a degree of epileptic brain dysfunction and a degree of structural brain damage, patients are going to differ in terms of where they sit on this spectrum. So for example, and this is something that we rarely ever encounter, a patient with an absence epilepsy and absence status, they can be in absence status for days. You stop their seizures, they will walk out of hospital. It is purely EEG. It's just purely epilepsy that's producing their cognitive impairment. A patient on the other end of the spectrum with post-anoxic encephalopathy and in coma from that, they may be seizing away on their EEG, but it's not likely producing any additional injury. So these patients are not likely to improve regardless of what you do. And I'll show you in a study in a moment that helps kind of understand that. Most of the patients, though, that we consider in this setting are going to be somewhere in here where we don't really know, the extent to which the EEG is contributing to the EEG findings, rather, are contributing to their impairment, and equally how much they potentially impact their outcome. So this question of, and this is the only slide I'm going to have on this concept, this question of post-anoxic cardiac arrest and the seizures seen in that condition was actually considered in a fairly large study in Denmark, or coordinated out of Denmark. It was multi-center in Europe, the Telstar trial. And here they had patients who were under continuous EEG, and if they're post-anoxic cardiac arrest situation, they were either treated with seizure, an attempt at least to control seizures, so anti-seizure treatment. They didn't always get them under control, or just control, not doing anything additional, beyond typical management. And they found that actually shooting for seizure control did not in any way impact their overall mortality. So it was the etiology itself that was driving the mortality, not treatment of seizures. Now, of course, everyone does subgroup hoc analysis, and there may be a cohort within this where active seizure suppression may be beneficial, and there are studies that are kind of looking at this question. But patients who have anoxic encephalopathy, unfortunately, to date, we don't have good evidence intervening on their seizures has a great benefit. So I bring that up because another European study, this one based in Switzerland, multi-center randomized, where they wanted to answer the question, I think to help their deployment of this over a broader cohort of patients, they wanted to ask the question, does continuous EEG monitoring versus routine EEG actually impact management? And so they looked at 364 patients, and again, it was randomized, and they found that, not surprisingly, those who had continuous EEG had a higher rate of seizure and status epilepticus detection and treatment modifications, but it didn't actually impact the overall mortality. Now, some of these patients were very late to be enrolled, which is a very important kind of consideration. And also, equally so, this trial did not include patients who had recent clinical seizures or refractory status. It was deemed unethical because this is, under the European guidelines, these patients require continuous EEG, so they would not be included. There was also a fairly large proportion who had noxic encephalopathy. And they found, again, post-hoc analysis, so when you excluded this cohort, there was a trend to, improved outcome with continuous EEG. So, the anoxic encephalopathy group really needs to be separated out in the future because, unfortunately, treatment of their seizures does not seem to have much of an impact. So, seizures are additively injurious. We have that in a question answered in a number of studies going back many years. Brian Young, who was in London, he's now retired, looked at non-convulsive status epilepticus, and it's associated with mortality in a time-dependent manner, independent of other variables. It's been looked at in the question of ICH, intracranial hemorrhage, where seizures are associated with increased mass effect, midline shift, traumatic brain injury, seizures, and status are associated with higher intracranial pressure and lactate pyruvate ratios, neurospecific enolays, biomarker neural injuries seen with seizures. So this shouldn't come as a surprise that we have to worry about seizures. The bigger question is what about these continuum, these interictal continuum activity features? Do we have to worry about these? So one study, this was out of Columbia, looked at patients who have these periodic discharges. That is exactly as it sounds. They have discharges that occur at a fairly regular basis. We see this all the time in patients with brain injury for multiple reasons. They looked at a cohort of 90 patients with subarachnoid hemorrhage who had a quite remarkable multimodal monitoring, including depth electrodes. So they put electrodes in the brain. That was just to help better understand what was truly seizure and what was not, and get the exact timing sorted out. They looked at monitoring. They monitored the partial pressure of tissue oxygenation and regional cerebral blood flow. And basically, they found that periodic discharges above 2 Hertz were inadequately compensated for, meaning the cerebral blood flow would increase to that point, but then plateau, and beyond that point, the tissue hypoxia would set in. They saw similar things with seizures, not surprisingly, but the periodic discharges, these activities that are usually formally considered to be interictal, seem to also be quite metabolically taxing and associated with tissue hypoxia. And obviously these people who have these findings, they're also at risk for, frank seizures. So associated with higher frequency of discharges may itself be metabolically taxing and potentially injurious to the brain. Another study looked at this question with PET. It's something that's obviously quite difficult to deploy, and seizures as well as high rate periodic activity was also associated with increased cerebral metabolism. So again, some of those things that are along this continuum may have an effect on the brain similar to seizure. So one very large and recent publication, again from the Mass General group, looked at a large cohort of patients who had continuous EEG, and they developed, and the paper goes into how they did this, if you're at all interested, a machine learning algorithm using convolutional neural network to annotate their records. There was a lot of training employed initially with human expert readers, but eventually an algorithm was developed and went through and annotated their like multiple terabytes worth of continuous EEG data and annotated these various epileptiform these epileptiform activity. So this plot here is all 2,000 patients over the first 24 hours, and this color schema is sort of what the algorithm labeled. And you can see, I think they're put in rank order, the most severe here. They calculated, if you will, the epileptiform activity burden. They did in a few ways, either over the first 24 hours, the peak burden, so the peak kind of 12-hour window, the highest calculated burden. It was on a percentile scale, so 100% would be continuous over that 12-hour period, and then the cumulative over the first 72 hours. Some of these patients obviously had very long monitoring. And all measures were, associated, higher value associated with poor outcomes. And there seemed to be a dose-dependent effect on the peak epileptiform activity burden. So the 12 hours with the highest amount of burden, there had an effect against poor outcome in these patients. And it was the greatest for patients with seizures, status epilepticus. And this is what this graphic is supposed to depict. They had a separate ones for each of the various indications. And it's stratified here by the time from the last monitoring to the discharge. But either way, you can see the linear uptrending on peak burden and probability for poor outcome. Now, one thing they didn't do, because they couldn't do, was try to model and understand if treating this activity had an effect on outcome. And that is another major question. So what about treating these activities are on this continuum? I mean, really, when we see someone with something like this, we're basically saying they have possible non-convulsive status epilepticus. We're saying we don't really know they wouldn't meet criteria for definite seizures, but is this something we need to worry about? Now, this is a very recent publication, and because there's very sparse treatment data on this, it was really just an algorithm by consensus, a Delphi kind of approach. So they, by consensus, came to the conclusion that therapeutic trials with a non-benzodiazepine, and they favored medications that were not going to promote sedation in a partial loading dose, could be tried, and these patients should be obviously monitored for effect. And in this way, you can trial patients who have something like this. So two things that would count as a positive response. Here's a patient with continuous 100% of whatever the intellectual continuum finding was. They get treated with anti-seizure medication, and they see a very clear break in that by their kind of benchmark. That would count as a positive response. Or alternatively, and this is the more likely scenario, we have patients who are sort of fluctuating in terms of showing activity at varied times and sometimes not. And they said if it was any period of time after the trial 3 times greater, which is fairly standard kind of statistical kind of rule of 3, that would sort of count as a positive response. Obviously, clinical responses count as well. This is just looking at the EEG alone. Now, again, this is just a proposal for study, really. There's no strong data on this. One of the things that the clinical neurophysiology and the ICU consortia are really good at is defining rules in advance and then finding the data for them, whether or not they pan out or not. One of the reasons this field has been quite successful in recent years is about a decade ago, they standardized the terminology. And once you have everyone using the same terms, you can start answering questions. So I think that is kind of the idea here. You get everyone kind of speaking the same language and using the same approach, maybe you can answer some of these questions. And really, there are still many questions that remain. Among them are, which patients are best suited for continuous EEG. I mean, we're now not in this country, we're now kind of 20 years into this kind of question. Thankfully, a lot of the hard work has been done. Some patients clearly are better candidates for this, and some patients, unfortunately, it's the resources are probably not as well spent. How long should they be monitored for? I mean, the earliest data was say 24 if they're non-comatose, 48 if they're comatose, but now potentially we can better stratify that based on some of the scores and models I showed you. What findings merit treatment? Again, a very open question. Some of these findings certainly have the hint of being, cerebrally toxic, but really there's no strong kind of treatment data for non-seizure patients with findings that are somewhere in between. So what are the effects of treatment? That's, again, for a lot of these things, quite unknown. And we should also bear in mind that you can overdo it, right? Our cardiology colleagues learned a long time ago that trying to control every single arrhythmia is not necessarily the best approach. So the CAS trial, of course, changed the course of cardiology a long time ago. And we have seen there's literature that, the overly aggressive treatment approach can sometimes be harmful to patients, especially, high dose anesthetics with all the complications that brings with it. Patients need pressors to overcome the vascular effects. So overly aggressive treatment can sometimes do more harm. So these are all things that you need to keep in mind. So we haven't been doing this to date at Hamilton, but there's a plan, hopefully, to get this going in the near future. So the provision of EEG, unfortunately, continuous EEG is below kind of the standard of care. The American and European guidelines would call for continuous EEG in patients with status epilepticus, for example. So we're trying to kind of get up to speed. And the idea is to start with, one or two studies, or the potential to do one or two studies at a time. And likely summer, maybe more like late summer, depends on a few other logistical pieces that are being worked out. And this is just a cartoon showing what the logistics are. Of course, patients, you need monitors, you need, and this is really where we're kind of struggling right now. You need to make the data accessible, right? Data is only good if it could be seen. So that's really where we need to kind of figure this out, because it doesn't make any sense to monitor someone and not report. So communication is critical. I've been in centers doing this, and it's really important to have a very clear line of communication between people ordering the studies and people reading the studies. So initially, and in part just to control resources, studies will have to be approved by the EMU staff or whoever's reading the case. This also makes us aware of what's going on. And then continuous acquisition, but intermittent review, that's the model everywhere. CNS would suggest at least a 12-hourly review, and that's I think a reasonable time frame. Now, if patients are very, very sick, there could be more frequent back and forth. And then being able to report back to the NICU team or whoever is relevant to the case. There's nothing more frustrating than opening a study, seeing a patient at status, and not knowing who to call, and spending your whole morning playing telephone tag, trying to find someone to tell. So we need to make sure that the communication is bidirectional. So yeah, I think we're largely on time. In summary, then, we've kind of gone over this idea. Continuous EEG is a very well-established diagnostic method to facilitate optimal patient care, especially of neurocritical care patients. Now, in truth, it's difficult to unequivocally establish, if you will, treatment effect. Of course, this is a diagnostic test. It's a diagnostic test that it could potentially inform treatment, but it's important to keep that in mind. And as I've shown you from a few studies, it's probably dependent. It certainly is dependent on etiology. Some patients, unfortunately, will do poorly regardless of how we intervene. but some patients potentially could have their outcomes greatly improved. And there are methods now, because there's been a lot of literature on this already, to help stratify and target the application. For example, the scoring method might be a useful way of determining how long a patient should be monitored for, or when it's reasonable to stop and, not waste, a day on a patient, for whom the machine could be better used. And also potentially to kind of treat the guideline of some of these funny things that we find, these things that have us scratching our head, not knowing what to do. There may be reasonable and informed ways of trying to see if we can have an effect. Of course, the long-term outcomes are still a long way off in terms of knowing the impact, but at least in the short term. So we went over a little bit of literature fairly quickly, and if you're at all interested, I've listed some of the, I think, more helpful studies in this field if you want to look them up yourself. But I think we have time for questions, comments.
Thank you so much, Dr. Thompson, for this overview and the futuristic work of continuous EEG monitoring in Hamilton Journal. If you have any question, please add it to the Q&A. And if you would like to be brought in to ask your question in person, please raise your hand and I will bring you in. So looks like we're very close to this happening at the Hamilton Journal, which is fantastic. I understand this is going to happen in the neuro ICU. Will there be a way to is there a patient population? I'm thinking about from the internist point of view, we have, those are the outpatient that you want to diagnose, and they have the EMU for, you have the ones in critical care, and you'll see what the benefit that you've outlined here perfectly. We continue to see within, in inpatient, sometimes, those patients that we're not sure, what their diagnosis is, or they're presenting for the first time, or they're coming in with these multiple seizures. We cannot take them the EMU, as you're aware, it's probably been done once in the last many, many years. Is there something that in the field, is there any evidence to use this modality for inpatient diagnosis, but beyond the EMU, or which is an outpatient scheduled intervention versus patient who's in hospital and we're struggling with their diagnosis of seizure or pseudo-seizure or whatever recurrent episode they're faced by,
Well, I can tell you also just from experience, there are many patients who are not critical care patients who are having, episodes, and you need to know what they are, and just routine EEGs is not going to serve that purpose. I can think of a patient fairly recently where I last worked. She was on the obstetrical unit and having funny spells, and they really wanted to know what they were. Reasonably so. They were non-epileptic. So it's good to know, because you don't have to advance treatment and start using drugs that could potentially be problematic for her and, unborn child. But yeah, hard data, it's a diagnostic test, right? So yeah, you will diagnose things, absolutely. If you look, how that changes outcome is harder to say, but hopefully the 1 to 2 studies we have is just the beginning. Hopefully we'll be able to offer this outside of the critical care units in the near-ish future.
And would those patients, out of just sort of technical piece, would they have to be in transferred, or is the machinery available to transport to different units and different beds? Because the EMU is a regular unit, so can be a regular medicine bed monitored continuously.
Well, so that's one of the very critical pieces, and that was the box around the little man in that diagram. That's actually the key piece right now. Yeah, so you can roll a cart next to a patient and record it, but how does that data get transmitted to someone so they can see it? So there are 2 approaches. You can put ports everywhere, or you can deploy it over the Wi-Fi network, and that's something we're still kind of weighing the pros and cons of. Because yeah, if you have Wi-Fi network with sufficient bandwidth, you can monitor a patient anywhere in the hospital at bedside.
That's fantastic. I think we just need to upgrade our Wi-Fi. Will work out, you know. I'm certain that also human power, human resources is a challenge in getting this monitoring every 12 hours. I understand, luckily, it doesn't have to be continuous. You've just shared with me that, you know, we are now 5 epileptologists in Hamilton General, which is fantastic news. I see Lewis's hands up.
Yeah, Lewis has got his hand up. So.
Yeah.
Hi, Lewis.
No, thank you, Stephen, for your presentation. Very interesting. So I just wanted to stress maybe, and maybe you can elaborate a little bit more regarding the fact that, you know, long time ago when I got here to Hamilton General, we looked at routine EEGs of 30 to 40 minutes. And certainly those that were taken in the first week of the patient in the ICU were very different than the one who was taken, you know, 20 days into being in the ICU. So I think that's an important criteria, because sometimes I understand the physicians, let's say, anxiety to know, but regarding prognostication and the time when the you know, how prompt should we be doing the EEG, what is your recommendation? The first couple of days, that study with the machine learning, it was the first hour of the EEG that they used. So now that would be
well, yeah, but it wasn't necessarily the first day of hospitalization. But yeah, obviously, especially with an acutely ill patient, the sooner the better. You know, that one of the criticisms of that study I showed you that was run out of Switzerland is some of the patients, it was, you know, 3 days into their acute admission, by the time they got all the consents worked out, that they started the recording. And at that point, if there's something terrible going on, it might be too late. So yeah, I think for many patients, and especially if you've had a routine that shows something very problematic and worrisome, the sooner the better. Of course, with only a few machines, it'd be really hard to you know, work out the logistics. But you're right. 20 days in and then asking the question is not likely to be as fruitful.
If I can ask another question, I don't know if you have any experience with CT perfusion and these periodic lateralized epileptiform discharges as a kind of a measure to see how the metabolic status is, thinking that it is epileptogenic or just epileptiform. I don't know.
Yeah, I'm not sure. I mean, there's some literature on various modalities, including like diffusion-weighted MRI, and like the PET. I can inspect. I'm not sure about CT perfusion, and like probably has been looked at, but I just don't know.
Well, I looked at some patients way back. I gathered about patients with PLEDs, and certainly there was hyperperfusion in the area where the PLEDs were. Obviously, it was not done exactly simultaneously, but within 24 hours. And so we do have now perfusion quite available for our patients with stroke. Dr. Cantanesa is almost a very good expert on this. So maybe that's something that could be looked into again.
Right. Yeah. It becomes a little tricky because of the EEG are, you know, beam hardening artifact, but like with the electrodes on for the CT, you have to pull them off. But yes, you're right. You could potentially ask the question that way as well.
Sure. Thank you again.
Yeah, thank you.
Questions and comment, Lewis. I do not see any other people. Another few seconds. Looks like no more questions, or people want to bring up comments. So I will give people a few minutes back. Stephen, thank you so much for this overview and a very useful new intervention and diagnostic modality that we're bringing to the Hamilton General under your leadership. And look forward to diagnose more patients that we're struggling with. So thank you
Yes.
very much, and thank you for the review of the literature. It's very useful and clear. So appreciate your time today, and I wish everyone good rest of their day. Thank you.
Okay. Thank you.